Selamat datang di program pendidikan vokasi Universitas Indonesia.
Welcome to Vocational Education Program of Universitas Indonesia.
Saat ini Anda berada di dalam gedung auditorium program pendidikan vokasi Universitas Indonesia.
Now we are gathering inside of the auditorium of Vocational Education Program of Universitas Indonesia.
Ruangan ini sudah dilengkapi dengan sarana dan prasarana yang berkaitan dengan keadaan darurat.
This room has complete with emergency equipment and safety guidelines.
Bila terjadi keadaan darurat, dimohon untuk tetap tenang dan jangan panik.
Whether an emergency happens, please keep calm and do not panic.
Keluarlah melalui pintu darurat yang telah tersedia di sebelah kanan dan di sebelah kiri di dalam ruangan ini.
Emergency doors are in the right side and the left side of the buildings.
Keluarlah menuju titik berkumpul.
Go out in the light to the assembly point.
Silakan berikan prioritas kepada ibu hamil, penyandang disabilitas, dan lansia.
Please give priorities for pregnant women, the elderly, and disabilities to go out first.
Di bagian koridor gedung ini telah tersedia alat pemadam api ringan atau APA, dan di luar gedung ini telah tersedia selang hydrant.
The fire extinguisher will easily find in the corridor, and there is a water hydrant outside the building.
Terima kasih.
Thank you.
Biarpun saya pergi jauh, tidakkan hilang dari kalbu. Tanahku yang ku cintai, engkau ku hargai.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Greetings to all of us. Shalom, Om Swastiastu, Namo Buddhaya. Before we start the event, let us sing Indonesia's national anthem song titled Indonesia Raya. Ladies and gentlemen, please stand up. Ladies and gentlemen, you are allowed to sit back. Next, we would like to welcome you to the Occupational Therapy Public Lecture entitled Current Trends and Challenges in Occupational Therapy Education and Clinical Practice. My name is Bianca Zahra, Occupational Therapy student, Class 2021, as the MC who will guide today's event, along with my partner.
And my name is Yosepin Talita, Occupational Therapy student, Class 2021. First of all, we would like to thank the Deputy Director of Student Affairs of Vocational Program University of Indonesia, Mr. Denny Daniel Kesa, MBA, PhD, then the Head of Occupational Therapy Student Study Program, Mr. Hermito Gideon, AMD, OT, MC. And of course, Mr. Muhammad Hidayat Sahid as the Head of Health Department in Vocational Program, and to all of our honored guests. And also, special thank you to our special keynote speaker, Mr. Sharif Ismail, PhD, MSc, from Chair and Professor Faculty of Rehabilitation Medicine, University of Alberta. All right, before we get to the main event, let me read the series of events from this public lecture. First, we will hear the opening speech by Mr. Denny Daniel Kesa, MBA, PhD, as Deputy Director of Student Affairs Vocational Program University of Indonesia. And then, We will see the special performance from Occupational Therapy Band, material session by Mr. Shanif Ismail, PhD MSc from Chair and Professor Faculty of Rehabilitation Medicine, University of Alberta, the question and answer session, documentation and submission of certificates, and after that, we will close our event today. Before we start, we hope that this public lecture can run smoothly until the end. Let's pray together according to our respective religion. Praying begins. Praying is enough.
The next event is a speech by Mr. Denny Daniel Kesa, MBA PhD, as the Deputy Director of Student Affairs Vocational Program of University of Indonesia. Mr. Denny Daniel Kesa, the floor is yours.
Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan, rahayu, salam bahagia. Today we have such great honor to welcoming Professor Shanif Ismail, PhD. Thank you, Professor, to come. I met him at the first time around 8 years ago. That at the start of a long journey from him to made such great collaborations with a vocational education program, and also Pak Dion, Pak Sahid. Good morning. Thank you for supporting this event, and also the lecturers from OT, and also from alumni, great alumni from class 98. It's very first time for me to meet you all, and also a lot of alumni here come to make this event more fruitful. This discussion or this speech might be a more good opportunity to us to make some collaboration to Alberta University. Actually, today students here, it consists class 2021, class 2022, and also we're coming to you to class 2023. Give a big applause to you for OT department. And yesterday, we speak and discuss with Professor Sani. I think the future of our collaboration will be start soon, because we doesn't want to get more longer to get collaborations, because today we have D4 or bachelor or undergraduate strata, but for futures we want to have collaboration more between us and Professor Sanip to getting a master degree, that we can collaborate in the futures. I think after you can studying here at D4, you can continue study to our master degree. Then we will be have some certificate from Alberta University, I think, and then we will be have plan for international accreditations from WFOT, and will be helped by Professor Sanif and Professor Sharon. Thank you, and give big applause to Professor Sanif. I think we will support, full support, because this is very rare opportunity to us to making collaborations. I think for next, students can go to Alberta University to get a program we call maybe professional program, something like that, and then we have a summer class or summer program. Even we can get funding from IISMA, Ministry of Cultures and Educations, and also you can by self-funding. It means convince us you very well and you can get that program. But don't worry, we also have a matching fund. It means you can funding by yourself in half, and the rest half we can support you from scholarship. And today it's very interesting, the current trends, challenges in occupational therapy education and clinical. But I heard from Professor Stanif in second term, you can you will be bring the topic. It's all about sexuality. It's very interesting, but sorry because I have another meeting today. So for so maybe I can discuss after this event directly to Professor Sanif. And hopefully for teenagers can learn and students can learn about this and how to make the OT very famous in the whole world, just like I discussed with your many alumni. The alumni of OT students is a very have big opportunity to in the job field. Then don't worry, the study program still consists to study program in Indonesia, in Solo and also in Depok. So don't worry about the opportunity to getting a better job. And on behalf of Papadang, our directors, we welcoming Professor Sanif and all students, also alumni and distinguished guests to make some great event for discuss in these public lectures, and hopefully success for all of you today, and very great day to all of you. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. That's it from me.
Well, thank you very much, Mr. Denny, for your warm remarks. Next, before we continue, we would like to do a documentation session first so that today's event can always be remembered. The audience, you are welcome to stand up. For those who participate in today's event online, please turn on your camera first. I will start the countdown. 1, 2, 3. Once again.
Mungkin yang dipikir boleh bisa merapat ya ke tengah. Yang tengah diisi aja. Okay, I will help for the countdown. 1, 2, and 3. Okay, thank you. Please have a seat.
Next, we will see special performance from Occupational Therapy Band. Ladies and gentlemen, let's give them a loud applause.
Good morning, everyone. On this occasion, we would like to present a song with the title name is Indonesia Jaya, especially for Mr. Sanif. Hope you like it.
Cek, cek.
Tiada pernah terganti 1000 rintang jalan berliku, bukanlah suatu penghalang.
Hadapilah segala tantangan, mohon petunjuk yang kuasa. Kobarkanlah bangsa, kobarkanlah dalam nada semangat jiwa Pancasila.
Hidup tiada mungkin tanpa perjuangan, tanpa pengorbanan. Jaya.
Hari-hari
Terus berlalu,
terus berlalu,
tiada pernah berhenti. Seribu rintang, jalan berliku, bukanlah suatu penghalang. Hadapilah segala tantangan, mohon petunjuk yang kuasa. Ciptakanlah kerukunan bangsa, kobarkanlah dalam dada semangat jiwa Pancasila. Hidup tiada mungkin tanpa perjuangan, tanpa pengorbanan, mulia adanya. Berpeganglah tangan, satu dalam cinta, demi masa depan Indonesia Jaya. Thank you.
Okay, thank you Occupational Therapy Band for this spectacular performance. I'm sure it took a lot of practice to serve such a great performance, don't you agree?
Yes, of course. And then we will go to the next event. Our main event of this public lecture, we will listen to various useful knowledge which will be guided by our moderator, Miss Sarah Wulan. Before that, please allow me to read the CV of Miss Sarah Wulan. I am delighted to introduce our moderator for today's event. Please join me in welcoming Miss Sarah Wulan as our moderator today. Miss Sarah graduated from Occupational Therapy University of Indonesia in 2018. She also has great achievements when she was in college, such as Mahasiswa Berprestasi or Outstanding Student in 2016, and the lead of IOTSA or Indonesia Occupational Therapy Student Association from the University of Indonesia in 2016. Ms. Sarah has 4 years of experience dealing with international and national play schools in Indonesia. She also has a remarkable track record as a school-based occupational therapist, like working as a school-based occupational therapist at Pro Education International School and High Scope Indonesia. And now, Ms. Sarah Wulan has been a founder, CEO, and Special Education Needs Coordinator at Clover Kids Center since August 2021. We are truly fortunate to have Ms. Sarah with us to navigate today's important dialogue. And all right, to the moderators, Ms. Sarah Wulan is welcome to take over the next event. Please give applause to Ms. Sarah Wulan.
Good morning, ladies and gentlemen. Dear fellow students, lecturers, and participants, welcome to the occupational therapy practice in Indonesia, the current trends and challenge in occupational therapy educations and clinical practice. I'm Sarah Wulan, your moderator for today. I also would like to greet our distinguished speakers from the Faculty of Rehabilitation Medicine, University of Alberta, Professor Shanif Esmail, PhD. Ladies and gentlemen, this current trends and challenge in occupational therapy, education, and clinical practice is held by Occupational Therapy Indonesia in collaborations with Alberta University. For the next around 3 hours together, we all explore and practice occupational therapy. Before the presentations begin, let me inform you how the sessions will go. First, Professor Shanif will deliver presentations for around 2 hours. And the second, we will go through the questions and answer sessions for 30 minutes. So ladies and gentlemen, before we start, I would like to present you the CV and our honorable speaker, Professor Shanif. Our speaker today, Professor Shanif. He is a professor and chair, Department of Occupational Therapy from the University of Alberta. Dr. Ismail is an occupational therapist who is best-selling author with clinical and research interests focusing on sexuality and disability. Specific areas of research interest include sexuality and disability, sexual health education for individuals with disabilities, and technology to enhance teaching and learning. Professor Shanif teaches various courses at the University of Alberta in the Faculty of Rehabilitation Medicine. Professor Shanif designed and established the first Canadian postgraduate certificate in sexual health at the University of Alberta, and he is the VP for the Alberta Society for the Promotions of Sexual Health. So without further ado, allow me to welcome Professor Shanif to the stage.
Terima kasih. Okay, so are you ready to start? We've had lots of introductions. We've had, what I'm going to do today is they asked me to do a presentation. So I said, what should I talk about? What is important to Indonesia in occupational therapy? So the first 45 minutes, we'll talk about what is occupational therapy practice in Indonesia? What are some good things, but also what are some challenges? What do you face here in Indonesia that maybe in Canada or other parts of the world we don't have a problem? Okay? Occupational therapy is very small in Indonesia, and we're going to talk about what needs to be done. Today, Vice Dean talked about partnership between University of Alberta and UI. The main thing we're looking at is, inshallah, if God wills, in the few years, we will have a S2 program for occupational therapists. That is very important because when you have an S2 program, there's research, there's also higher level. So there's recognition. But the other thing is, many of you who do S2 can then become lecturers, professors. Because in Indonesia, there's only 2 programs. You have a what? 3,000, how many OTs do you have in Indonesia? About 3,000? 2,000, 3,000, you know, not very many for 240 million people. In Canada, we have what, 30 million people? We have 25,000 OTs. In Japan, they have over 70,000 OTs. So Indonesia is very small. We need to make more OTs. So the only way we can do that is to do higher level education. Okay, but we'll talk about this. So today, can we put up the PowerPoint, please? Somebody? Is someone going to put the PowerPoint up? Oh, there it is. Okay. So today, let me turn on my switch here. All right. So I'm going to do some introductions. I'm going to talk about current trends, but I don't know what's happening in Indonesia, so I'm going to ask you. Then we're going to talk about what are the problems here in Indonesia. And then we're going to talk about why is occupational therapy so special? What makes us different from other professions? Okay. And then we'll talk about our practice and then just some questions. Okay. One thing, all my slides, what I've done is I've used, I put translation. So there's Indonesian, Bahasa Indonesia. So if you have trouble understanding, please, hopefully the slides are correct. I used Chat GPT AI to do the translation. And we know a lot of you use it for classes, but you use it to understand. As long as you learn, not just use it to submit assignments and save time. All right? We'll talk about that a little bit too. So, where am I from? I'm from Canada. In 2005, I came to Indonesia and had meetings in UI, but also at Solo. Way back in 1990, I was a S2 student, and we had 4 Indonesian physical therapists come to Canada, and I was there to help them learn English and go through our program, so they became OTs. Then they came back to Indonesia, and they started the Polytechnic occupational therapy program in Surakarta. Okay. Then after that, UI started a program. So now we have 2 programs. Not enough. Okay. So I'm from Canada, Edmonton, Alberta, and it was our program at the University of Alberta that got a World Bank and Canadian International Development Agency funding to actually start in OT in Indonesia. So I've been around since the beginning of OT in Indonesia. So I'm from Edmonton. This is by Edmonton. It's Banff, Alberta, beautiful mountains. We have a lot of snow and ice. It gets very cold. So this is sort of, we do a lot of things like ice castles and things like that. This is again Banff, Alberta. This is my family. My 2 boys, Kambar, okay, twins. And my daughter, I don't like her. She's a physical therapist. No, I'm just kidding. She was accepted into OT and PT, but because her father was in OT and I was head of the program, it'd be very difficult for her to be a student, so she decided to do PT. We'll accept that, okay? It's still rehab. And that's my istri, Yashmina. She's my ibu-ibu, okay? She tells me what to do. She's my boss. All right? This is our dog. His name is Ozzy, okay? He's 15 years old, so very old now. And that's my family, okay? This is my house. This is my house in Edmonton. We live in this house, okay? Everybody asks me, where do you live? So I put a picture. And those are my children when they were younger. We have to shovel snow because otherwise you can't get out of the house. All right, so now let's start. Today, we're going to talk about what is the current trends. Now, when I say trends, what is happening in Indonesia today regarding occupational therapy? So, Rathna, where are you? Rathna. Okay, Rathna. Who's your friend there? Ika. I'll ask Ika this time, okay? Ika, what is happening in Indonesia right now for OT? If you were to say, where do OTs work? What types of things? Pediatrics, right? That's the main thing? Okay. So I'm going to give you a little token for trying to answer. Here you go. And Rat, because you chose her, you can have one too. All right. All right. So what is happening in Indonesia? Where's practice? Where do OTs work? Alif? Right? Is that your name? No, I'm sorry. What was your name? Restu. So tell me, where do OTs work? Hospitals, in schools, clinics. But what is the main thing? What are the things that are happening in OT? Are you considered part of an interdisciplinary team? Are you seen as equal to physical therapy, social works? It's like not yet, right? Why? What is the problem? They don't know us. That is the big one. Good one, Tofik. They don't know what OT does. Okay? That's a big problem. But it's not, I mean, it's not a problem you can fix overnight. The only way you can fix that problem is to have many more OTs. Even my mother, when I became an OT 30 years ago, I became an OT in 1988 or 89, long time ago, before many of you were even born. Okay? Huh? 40 years ago, yes. Oh no, yeah, then less than 40, about 30. I'm not that old. But the reality is, I remember when I told my mother, I'm going into OT. She goes, what's OT? She didn't know. Even in Canada, 30 years ago, we had a problem. But today, if you say, what is an occupational therapist? They all know. If you say, where are you working? They'll tell you where OTs work. Tofik was asking me, where do people OTs work? Or was it like, and I said, well, it's mixed. Like here in Indonesia, most of you work in hospitals, but mainly pediatrics, neurology, a lot of autism, like very specialized. And the problem is, some of you work in very specialized clinic. And who can use those clinics? People with money. They pay for your services. But you need to make money. You need to live. So the reality is you need to do that. But what that does, it makes it very limited who has access to OT. In Canada, we have OTs maybe 20% working, 10, 15% working in pediatrics. 10, 20% working in work, where you go out in industry and work with that. We have about 10, 15% working, 20% with older, or like geriatrics, or more than that. And then you have OTs working in psychology or psychiatry, mental health. So it's all spread out. Here it's very specialized, and that limits. Okay? So I've got here, what are some current trends? One thing that's been impressive is technology. On Saturday in Surakarta, there's a conference, and I'll be presenting on technology, use of artificial intelligence in healthcare and education. And then on Sunday, I'm doing a 3-hour workshop about technology and OT in the 21st century. And what I'm going to talk about is how technology is important, but we can't forget why we are important. We do things differently, okay? So technology, telehealth services. Another thing that's really becoming very important is mental health. Not only in Indonesia, but also in Canada. People are starting to see the value of what OTs do in mental health much more. They're realizing that we do a better job than psychologists, psychiatrists, because in social workers, they just talk. We do. We actually help patients go from having difficulties, illness, to actually being able to do things. And that's really important, okay? The other thing that's starting to happen is people starting to realize we need an OT on our interdisciplinary team. So now they're starting to realize the value of OT, but it's very slow in Indonesia. And the other thing is there's more emphasis on community-based rehabilitation. In Indonesia, you have what? Over 17,000 islands. You're an archipelago. So you have such a wide land and distance and people and cultures and so many different types of people, languages. Even Indonesia has so many different levels. You go, I'm trying to learn the basic words, right? So it becomes very complicated. But what they're realizing is for healthcare to happen for all Indonesians, there's not enough infrastructure to do everybody. So now they're saying maybe we use telehealth technology to reach people in clinics, okay? And the other thing that's really happening a lot is artificial intelligence. That is a big trend because you can go into your computer and you can go in and access the same content that my students in Edmonton or Canada can do. So now it's equal. When I first came to Indonesia, one thing that I saw is you didn't have enough books, you didn't have any resources, and I felt sorry because there was not enough things. But now with computers and AI, you have access to the same knowledge that anybody in the world has. So automatically, it makes more equal. So what that does is it allows you to do more. Okay, so these are things that you need to think about. But what are the challenges? Limited awareness, already said that. Small number, and I say trained occupational therapists. This is a problem. And I've talked to the UI professors yesterday. We had a meeting, and I said we need to change. In Canada, we used to talk about training occupational therapists. Now in English, there's the word train. It means you're teaching skills. But we're going to change that because that is a very low level. And we look at you train occupational therapy assistants. You educate occupational therapists. What is the difference? I might know how to do a skill, but when you educate someone, you're able to think at a higher level. So what we need OT to do is be able to think at a higher level. And that's why the D4 is so important. Before it used to be a D3 program. Now you've moved up to D4, and which is equal to bachelor's, but now even going up to a S1. Because our students in Canada, they're not as good as you when it comes to skills. The hands-on, you guys get more classes and more things because yours is a 4-year program. So you have more skills than my students and my graduates. So the average OT in Canada has less skills than you. However, the OTs in Canada, their job isn't to just do basic stuff. Okay, that is for the assistants. That's why they have assistants. They are professionals, so they have to think at a higher level. So they do the evaluation, they do the assessment, and then they decide, and then they say, okay, now you do it. There's someone else to do it. And that's the model we need to do in Indonesia because there's only 2,000 OTs. And if you're all doing basic, day-to-day stuff, you need to be at a higher level so that you can have assistants that can do more. So we need to start changing, but part of that is educating OTs, not training them. Okay? Limited access to professional development. That is changing now. Because you have computers, internet, and all that, you just have to go in and Google, and you can find lots of different workshops and sessions and YouTube videos and TikToks and blah, 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 right? There's so much in social media and all that. So in terms of professional development, you can easily access it. Also, I'm happy because I was very impressed. When I went to UI, they gave me a tour yesterday. You have better equipment than we have in Canada. Now you're saying, what? Canada is a rich country. I was telling them, here, the poor professors make very little money. Okay, even OTs make very little money. But what they do is instead of spending money on people, they spend it on infrastructure, your rooms, your labs, everything is really good. Okay? In Canada, they spend all the money on people because they have to pay high salaries, but then there's no money left to buy equipment and some things. So like my program in Canada is very good. We're rich. But other programs in Canada do not have the same. So don't feel like you're going to a second-class program. You have better equipment than Canada or US, way better than US. Okay? US is not that good. Everybody thinks, oh, US, no good. All right? I've been to a lot of different programs. Difficulty collaborating with other health professionals due to lack of interdisciplinary understanding, because other healthcare professionals don't know what OTs do. So they don't know how to use you, and that way they don't ask for you. What we need to make sure is, what we also do in Canada is the OT students used to go to the medical students and dental, like all the different professionals, and talk about what we do. So they learn, they say, oh, OT can do that. Now, many doctors and stuff say, I'm not going to work here unless I have an occupational therapist. They insist on having OT there because we're so valuable. We need to change that here. Financial constraints, money. Okay? Big problem here is there's only a few of you, and there's not a lot of jobs in hospitals and stuff, so you work in private clinics and stuff because there's private money. People who have money that can hire you, and you have to have money. But the problem is that also puts it, we've talked about it, keeps you very limited. So those are some of the problems here. We need to start changing. The other thing is medical model. Who can tell me what the medical model is? Anybody? Well, think of it this way. The medical model is how the healthcare system works here in Indonesia, Canada, everywhere. Because usually you have the doctor who sees the patient, decides what happens, and then they refer and get other things, right? And then the team is made up of OT, PT, nursing, all of that kind of stuff. Well, in Canada, it's changing. Before, the doctor used to be top. Now, the doctor is not the top anymore. They're part of the team. And believe it or not, in the next 10 years, this is YouTube, going on YouTube, right? But in the next 10 to 15 years, the doctor's role in healthcare will become less and less and less. Why? AI. 3 weeks ago, I went to my doctor, and he says, you haven't had your tests done, my yearly test. So he sent me to the lab. They took blood, they did ECG on me and all that. And what happened was, in Canada, when you do tests, the tests go up into a website, and then I can see my own results. So my ECG had a problem. It said abnormal ECG, and it gave some information. I didn't understand it. It also said my blood sugar for diabetes is a little high. I go, uh-oh, what should I do? So I phoned my doctor, and he goes, oh, well, they said, oh, we'll get you an appointment. August 24th is my appointment. So it was 1.5 months later that I'm getting an appointment. My ECG is abnormal. What the heck's going on? So you know what I did? I used AI. I put my information in. I have a smartwatch, Apple smartwatch, and when I exercise, it takes my data. I put it in there too. I put all this data, and then it came up and said, you exercise too hard. Your heart rate and your blood pressure is a little high, and what that usually causes is the left ventricle to hypertrophy, become a little bit bigger. That causes abnormal ECG. Most likely that is your problem. Okay? Then in terms of my blood sugars, it says that it's an average of the last 3 months. And because I was in Europe and maybe eating too much sweets and stuff, my blood sugars probably went up, but I have to be careful now. But I'm at pre-diabetic. So then it told me what to do. I guarantee you, my doctor doesn't understand that. Like the blood sugars, maybe, but the heart problem, he would probably, you know what he's going to say when I see him on August 24th? He's going to say, oh, let me send you to a specialist because he doesn't know what's going on. Then they'll do more tests. But what I'm trying to say is the medical artificial intelligence is so good right now, but they're not using it. You know why? Money. Because they're trying to figure out how to make money. And also, the doctors are really pushing back. They're saying, oh, no, you need real people. But what they've shown is AI can do a better job of doing all the different things than the doctors do. So guess who's going to be really important in 10 years in the healthcare system? Occupational therapy. Because what you're going to do is actually work with the patients to help understand what the AI will tell you what to do. But you still need somebody to take that information and make it happen. Because what do OTs do? We allow people to get independence in self-care, productivity, leisure. And that's what it's all about. All right. But one thing, we still have to work in the medical model in Indonesia, because that's how you get paid. That's how people understand you. You're not ready to move beyond the medical model. In Canada, in the US, OT is moving away from the medical model because we're saying we can do more. And we're saying that we are outgrown, we are more mature to just work in the medical model. Because we look at health promotion, we look at quality of life, we look at all of these things that we don't do just in the medical model. In the medical model, you have a diagnosis and you treat the diagnosis. In our model, we look at bigger things, but in Indonesia, you still have to, until you gain recognition. Once you gain recognition, then you can move further. All right, so what is occupational therapy? We look at basically where it's a form of intervention that allows us to look at function, everyday life. The problem is, if I went and tell you, I have a knee problem, and I need to go to the doctor to get my knee fixed, and they'll fix it or do surgery or whatever. That people understand and that people can pay money for. But if I say, I'm having trouble sitting on the toilet, people are going to, well, I'm not going to give you money for that. You know what I mean? Because sometimes people think what OTs do isn't that important. But believe me, when you have trouble sitting on the toilet and not being able to use the toilet, you got a problem. Then people realize, oh my God, this is important, right? So the problem is, because OTs do such basic everyday things, sometimes people don't see the value. But what's going to happen is when AI and all that replaces the physicians, the doctors, our value will go up, because we're going to talk about function. How do we get it? So, what does this all mean? Occupation. How many people are either OT students or OTs here? Put up your hand. All the OTs and OT students, put up your hand. Come on, proud, be proud. You're an OT or OT student. You're not? Yeah, you are. Okay, why aren't you putting your hand? You guys are OT students. I can see you got the yellow jacket. So put up your hand. Okay, you're all OTs, right? What about way back in the back row? Are you guys OTs? OT students? No? Oh, they're professional programs. Well, we'll accept you back there. Okay? All right. Now, I'm going to ask you, you're being educated, trained to be OTs, or you already are, you're alumni. So tell me, what does occupation mean? We'll ask this young OT here. What does occupation mean? Oh, well, you need to go to school to become an OT, right? You, Mom? Are you OT? Okay, so what is occupation?
It's a job. It's a um what is something that entitled in yourself.
Wonderful. That was good. I thought first she said job. I said, oh no, she got it wrong. But then she corrected and built on it. What is occupation? Occupation is what we do. Yes, we can talk about work and leisure and all that kind of stuff, right? But occupation is much more. In Canada, most of the programs have become a very occupation-focused program. But that is moving away from the medical model. In Indonesia, you need to consider occupation, but you still have to think about diagnosis and medical things, right? So what is occupation? It's basically what people attribute meaning and purpose. Again, like I don't know your name, but you said it's something inside, something we connect, right? So it's not just work or job related activities and things like that. Occupation really is important. So if I said OT is a part of our core, occupation is part of our core domain. But if I said, you three, what I want you to do is on a piece of paper, I want you to take notes of what I'm saying. I want you to draw a picture or anything you want. And I want you to just make lines. Okay? Now, all of them are doing the activity of writing or whatever. But now, because you're taking notes, depends how she's going to take notes. She's going to take notes and saying, oh, this is important because I'm going to be an OT and I need to understand about occupation. So she's really connecting to the information and saying, okay, that's really good. Okay? Or she might say, he's making me write notes. I'm just going to do whatever and I don't really care. Okay? If she's not connected to it, then she's just doing a task or an activity. But if she really connects and sees importance and value in it, then it becomes an occupation. At the same time, I told her to draw pictures. If she's drawing pictures of, good thing we're not doing sexuality, then, we don't. But, if she's just drawing pictures of, her house and blah, whatever, maybe she's thinking, oh, I really enjoy I went to Bali and I went to the beach, and she draws a picture of that. So then she's connecting to that. Or I could have said, draw a picture of a dog. She doesn't like dogs. She's Muslim, right? No, whatever. But then basically she just might draw a dog because I told her to, but she doesn't care. Or she starts drawing pictures of what I'm saying, but pictorially. So she's taking notes, but she's actually taking pictures so she connects to that information. Again, it's more value. And then him just squiggling lines, it's meaningless. So he doesn't connect and he just says, why is he doing that, right? So what I'm trying to say is no matter what someone does, just because you're getting them to do it doesn't mean it has meaning and value. We need to really see what's important to the patient. My clicker is not working. Did I turn it off? Can someone Oh, there it is. Good. All right. So what is the importance of occupation? We need to start looking at what we're doing, right? So now, I've already talked about activity, occupation, and all of that. The big difference is not all activities are occupations, but activities can become occupations. Okay, so you really need to think about how you're doing that. And I've got actually a hierarchy. You have movements. If I just move my arm. There's actions, so I'm waving goodbye or whatever. There's a task, so I'm doing something specific. There's an activity that puts a bunch of tasks together into something that's productive. But occupation is where it starts to have meaning and purpose. Okay? Now, why is that important? When something bad happens, whether it's disability or environmental disaster, climate change, whatever, it can disrupt occupations. Okay? Now, when I had my ECG test, one of the things my wife said is, you're not allowed to exercise like heavy until you go see your doctor. Okay? So what happened is, one activity that I do is I play sports and things, but I couldn't do that anymore, and suddenly I was trying to do other things to do exercise. But I don't like going to the gym and just doing weights. That's not meaningful for me. But when I play sports, I can get my heart rate and all that, but I'm playing, I'm competing, trying to win. All of those have meaning to me. I enjoy it and all of that, as opposed to just doing exercise at the YMCA. So things you need to look at and when there's some sort of problem, that disrupts my ability. So I had a problem, now I can't do it. So suddenly I have a gap in my life, and we need to look at that. Oh, what happened? We lost the PowerPoint. All right. So what do we do all of that? Now I'm going to just show you some models of practice. Which model of have you learned in class while you're being for your classes? MOHO? Which other ones? Have you learned the Canadian model of occupational performance? CMOP or CMOP or CMOPE? You guys know these? Have you seen them? Some of them go no, some yeah. Okay, in Canada, way back in 1980, we had the occupational performance model. It had self-care, productive leisure, etc. Then in 1997, they changed it to make it the Canadian model of occupational performance. And the big thing they added in there was spirituality. Not religion, but spirituality. It was part of, so you had self-care, productivity, leisure. No, I would say physical, affective, social, and spiritual. Then, that was OPM in 1980. Then in 1997, they moved spirituality from side to the center, because they realized one of the most important things is what gives people meaning. Okay? Then in 2007, they changed the model again, and they added the word engagement. What is engagement? I know you get engaged when you get married, right? But engagement is where you're doing something and you are actually wanting to be involved. Exactly, good one. It's when you're involved. So some of you today are listening to me and really engaging. Then some of you are going, oh, you're on your phone and whatever, and you're thinking, when does this go over? Because I want to hear about sex, right? Sexuality. So that's when you want to get engaged, because that might be interesting, and this is not interesting to you. So are you engaging in what you're learning? Are you engaging in your task? Are you engaging? And that's really important. Now, guess what? In 2022, just this last year, they've come out with an even newer model. And the big part of that model is moving from engagement to participation. Okay, what's the difference? Now, I know these are all English words and all that kind of stuff, but engagement is where you are, you're connected and whatever. Participation, I'm sorry? You're being. Thank you. You're so good. Did I give you gotta give you something. I'll give you something really good, something better. Don't worry, I'm going to give you something really good. Okay, participation is where you're part of, you are in it. That's really important. So when I say you are occupational therapists, are you engaging in your profession? So engaging is you're doing your job, you're doing it good, then you go home, have your babies, you have your children, you have your family, and that's it, and it's a way to get money. Or are you participating in your profession? So are you going out and doing workshops and, where you're not getting paid, but you're actually teaching people at OT? You're trying to move the profession forward. Are you taking that professional responsibility? Okay, in the same way, when you're patients, are you getting them to engage in their therapy or actually participate in, they can see, I want to do this. I want to get better. I want to do this. What's important to me is really this, this, and this. Not what you're telling me, but what I'm telling you. So you're working with, it's called collaborative participation. That is the newest area. But notice in Canada, we've moved from, physical, whatever, to more this whole thing where you're working with the person. And with the new technologies and everything, it's going to be even more important about participation, engagement, and all of that is really important. Does that make sense? Okay. No matter what, whether it's Moho, Kawa, all of those models, they have a theoretical foundation of client-centered practice. You all understand client-centered? Or you're working with partnership, etc. They all have a developmental perspective, so you can look at children and how we go through different levels of learning things. And they all have an environmental component, context. That is so important. No matter what, for you to have occupation-centered practice, you have to consider the context or the environment. So what kind of environment is your patient coming? I was saying yesterday, we were talking, and I said, you give a case study to your students. Say, okay, come up with a treatment plan for this patient. It's a 12-year-old boy. He has autism. He has inappropriate sexual behaviors. He has outbursts in the class. He has all of these problems. Come up with a treatment plan. So, what's your name? Ashifa? Ashifa, she's a good student. She, gets a couple other friends and they're working and they're coming up with a treatment plan and thinking about all this. Well, what's your name? I'm sorry? Honey? Honey here, she's kind of lazy. But just joking, but she goes, you know what? She just goes to her computer, goes to ChatGPT, puts in the case study, it gives her a case study answer, and she submits it. Who learned something? You learned. You didn't, right? When they mark it, you might have got a better mark because you might more complete or whatever. It's written better because ChatGPT did it, and it translates really good into Indonesian. You're fine. But at the end of the day, you didn't learn anything. But the problem is, it's one thing to do a case study and come up with an answer. So that's what the computer AI can do it for you like that. And yeah, you can say, as an occupational therapist, can I do that? But the problem is, you're working right now, right? Okay. Think about your patient, your real patient, the last one that you have. Can you give me an example? Yeah, just your most recent patient. Don't give me names, just what kind of patient is it? Oh, sorry.
I work in school base. The case is
just one patient.
Okay. The kids come because they can follow or attention or engage in class because they are so distraction, or because lately we have COVID, they're not ready to the lot of people and then scared. Yeah.
So let's imagine that the patient that she's working with, his name is Adil. He's 12 years old has autism, has hyperactive disorder, attention deficit. He does some inappropriate self-stimulating, like he rubs his, things like that. So there's a lot of things that are happening. When you do a case study in class, you can't have all that detail. Now, when you're working with that patient, you're seeing them. Now, you can have the exact same patient with same diagnosis, but they're so different because this student, he comes from a very poor family. The mother doesn't have time to take care of him or teach him at home. Okay, while if you have a patient, let's imagine it's the same diagnosis, but that patient comes from a very rich family. So they have servants to work with the child, do different things. They can buy equipment, supplies, and all that. At the same time, that child has had lots of tutors and has other professionals working with him, while this other child, Adil, has nothing. He doesn't even get enough food every night to eat. So your treatment is going to be so different. The computer doesn't know all those things. And there's also, when we do sexuality later on today, when you're talking to a patient about sexuality, right when you talk to them, they might be very scared and embarrassed, or they might be very open about it. So right away, based on your interaction, experience, and context, it changes what you do. And that's what we do as occupational therapists, is we work with the patient. So no matter what kind of technology and all that, it's not going to be valuable unless you are considering what is meaningful to the patient. Even in a medical model, you can still do that. So what happens is if you do that, your patients are going to say, wow, that OT really knew what was important to me. So then they tell other people and say, that OT was amazing. So then it slowly develops recognition, all of that. Does that make sense? All right, so I'm not going to go through these models, but here are all these models that we've talked about. Engagement we've talked about. This is the new model that's come out in 2020. I hate the diagram, but it talks about basically participation, occupational participation and occupational performance. Actually, this should be participation in the middle. Again, occupational participation, I'm not going to worry about it. But the main thing is looking at two essential considerations: meaning and purpose of whatever you do, and what are the possibilities. So this is what you're talking about, is allowing people, if they're doing something, what are the possibilities of what you're doing in terms of improving function? And it fits very well with the ICF, and also it fits well with the recovery model, social model of disability. And the other thing is, I'm not sure if you get a lot of this in your program, but we do a lot of critical theory. What that means is we look at what we're doing and we analyze it from a critical lens. So we're kind of saying, well, how can we look at it differently? So we're really trying to question everything we do to make it better. All right, so in the end, we're trying to look at what's meaningful for patients. And as role of OT, basically our role is to improve the quality of life. The value of human touch is really important, and technology is going to be becoming more important, but we can use it for better. Think of it. You should go to your government people, or you should start, say, maybe even a private investor, and saying, you know what, let's set up a program in some remote region in Indonesia where you set up video conferencing, or you could do it even as a school thing where you can do it as a project where you could get a community in a remote region that don't have any OT services. And then you could actually have video conferencing. If you got internet, then you can do connection where you have some local person who's working with that, and you give advice and strategies. So what you're trying to do is provide services to areas that don't have services. In Canada, way up in the northern Canada, where it's really all just like nothing up there, we have indigenous people, the native Canadians, and they don't have much services. So what we're putting in is remote service delivery. And then our students are actually going to work with local service providers to actually provide services. So they're not going up there. It's like 8 hours straight north driving, very far, right? So we're going to be doing the same idea you can do here to start expanding OT services. So what is occupational therapy services? I've already talked about this. We talked about what is your scope of practice? What is your knowledge? Think about knowledge you have. I've looked at your curriculum. You get so many courses, too many courses, I think. We've talked about that. What is your competencies? You have some skills that people don't get, other programs don't get. What makes you special? So what you need to do is show other people what makes you special. And we know about this. So at the end of the day, as OTs, we look at these 4 areas. No matter what, this is the 4 areas that OTs always work on. Function, occupational performance and self-care, power, leisure, health and well-being, quality of life, but always with an occupation focused. And I've already talked about the problems in our profession, and I won't worry about this. And this is the World Federation of Occupational Therapy, where hopefully, inshallah, within a year, UI will be accredited. That is our goal, right? Because we want UI to be an accredited World Federation of Occupational Therapy accredited program. And your program has all the infrastructure. We just have to get the documentation and get it ready. And finally, this is what we do. So I said, don't ever give up. Don't feel like sometimes when you feel like you're a small fish in a big pond, you feel like you're getting nowhere. What you need to do is say, okay, I'm a small fish in a big pond, but this is my area. How can I make a difference? Okay? So when we talk about current trends in occupational therapy, OT in Indonesia is very small, but it's growing. And the only way it can grow is with you guys. So that's your responsibility. Terima kasih. All right. We are going to have question answer, but let's take 1 or 2 questions. Do you have any questions right now? And then we'll take a 5-minute break because you might need to use the toilet or something. Get some water. Any questions? Don't be shy. You know what they say, not asking a question is a lost opportunity. This is your opportunity. Yes! All right.
Hello, Mr. Sanif. My name is, let's just call me Ali in this case. While I'm a first woman here, that was a fascinating for me, especially for your presentations. Well, I did learn so many things, include for the collaborative experiences and all the things that you have said. But my question is, so is this job, or especially for you as an occupational therapist, could perceive could serve also a poor people. So you, as you said before, it is include money, and this is the like people I have made around me is totally arguing about money, and they just they told that we just serves rich people and just arguing and dealing with money. So in this case, especially for developing countries as Indonesia will we serve poor people or everyone beyond that besides money or anything else like that?
Very good question. One thing about occupational therapy is one of the strong parts of what we do is social responsibility. And we need, as a profession, there's this underlying philosophy that we're here to help people, okay? But there's also a reality. You need to eat, you need to take care of yourself, And many of you don't come from rich families. You have to take care of yourself. You have to bring up your own level of socioeconomic status. With status, you have influence. Okay? But that doesn't stop you from social responsibility. So what you might do is Monday to Friday, 8 to 4, you work in the clinic making money. For the rich, we're paying you to do that. But maybe on Saturday, instead of going to the mall, you go to and do some some social, like doing some work with a place with children or something who don't have any services, with the poor. And one of the things, for example, even in Canada, we have some really poor people up in the northern areas, indigenous. And what we're trying to do is, it is difficult because their whole population is very underprivileged, underserved. So it's impossible to change because there's also a lot of alcohol, drugs, and a lot of negative things, right? So the way we're approaching it is, instead of working with the whole population, we say, where can we make a difference? And you know where you make a difference? Children. What you want to do, and the other place you make a difference is mothers. What you want to do is work with mothers and children to change, like, how do you allow the child to become more successful? So the thing is, you say to the mom, you got to really work with this child so they can go to school. Make sure it's really important that they learn how to read, write, etc. So once they start developing that, you want to try to look at success, and then also basic nutrition, basic things. Now, if they have a child with a disability and stuff, and again, when you're working with underserved, poor, it's not just about disability. The environment in Indonesia sometimes does not take care of the poor, right? So this is what we need to do, is start working with this population so we can uplift the whole people, it's called. Like, not just the rich get richer. What we need to do, and you know what I've seen, just even being here, that there is a little bit better. Like, Indonesia is doing better compared to 10 years ago or 20 years ago when I first came here. I'm finding that the social, economic, and just overall, it's a little bit better. It's slowly, but it's happening, right? Someone was telling me yesterday that Japan just came in there and pulled a factory, and they're moving it to Thailand because Indonesia wanted to pay their workers a little bit more, and Japan didn't want that. But that shows that the government is starting to care about the people and making sure they're getting minimum wage and all that kind of stuff. So these are slow changes, but we can make a difference. Okay? Any other questions? But we will have, I think, half an hour at the end. So how about this? It is 10:20. So at 10:25. So in 5 minutes. 1, 2, 3, 4, 5. 5? Okay. Yeah. So in 5 minutes, we will come back here and we're going to do sexuality and disability. Okay? Oh, sorry. Do you need to do something?
It's okay. Thank you.
Okay, we're going to start in 1 minute. Ask you lots of questions. You know, all the stuff you can talk about. The sexuality PowerPoint, please.
Dear ladies and gentlemen, we are going to start the second sessions of Professor Shanif's presentations. It's about the sexuality and disability and occupational therapy. For Professor Shanif.
I'm going to tell you a story to begin. The first time I came to Indonesia was in 2004. And me and Professor Sharon, she's a professor in our department, we came to UI. And they heard that my specialty was sexuality. So what they decided was to have a sexuality full day or full morning workshop. So they had many speakers, or no, they had 3 speakers, I think it was. And the first, no, there was only 2. There was a doctor, and he was Indonesian, but he trained or he worked in San Francisco or somewhere in the US. And then he'd come back and he was working in Indonesia, in Jakarta. And his area was sexuality. And then I was talking after him. And I was sitting there listening, and his presentation was very inappropriate. You know why? First off, sexuality is something that's sometimes it's difficult to talk about. It's very personal. It's even when you talk to your patients about it, it's not something you just talk about like everything else. And Indonesia is a very conservative, primarily Muslim country. Doesn't mean you don't have sex. You have 240 million people, so you must be having sex one way or another, right? But the reality is it's something that's private and personal. So this Indonesian doctor had a PowerPoint and he was going through, and some of the pictures he had in there were very inappropriate. They were almost pornographic. And I was offended, and I teach sexuality. Now, why was I offended? I was offended because what he did was he scared a lot of people. He made people feel uncomfortable. Sexuality is a natural part of who we are as human beings. But we aren't trying to sensationalize and use it for jokes and whatever. Sexuality should be something that's very personal, very private, and you need to work with your patients in a very confidential, sensitive manner. Do you understand what I'm saying? So after the doctor finished, I came on and I actually talked about that. I don't think he was very happy with me. He was a short man. He wore this white. I have pictures of him somewhere in my things, right? Because we have pictures from that presentation and there's all these students. And I also realized that in Canada, we're S2 program. So my students are already finished a bachelor's. So minimum, they finish high school, they've done at least 4 years. So they're much older, and also their experiences may be a little more, available. Now things have changed. You have the internet, and I'm sure you can get into a lot of different things and find out about things. But many of you finish high school, so you're only 18, 19, 20 years old. My students are all 24, 25, 26, 30, 40, some older than me, but So what I'm trying to say is we're all different. We all have different experiences. So don't feel, I remember at that presentation at UI, this is in 2004, one student came up to me after, very shy girl. She comes up to me and says, how can I talk to my patients about something I don't know or have never done? Okay, she has never had a sexual experience. And she says, how am I supposed to talk to somebody about that when I don't know? Now think about yourself. Some of you might be very sexually active. Some of you may not. Okay, it depends on all of you. But the reality is, Just because you haven't had experience doesn't mean you can't work with somebody, because what you're looking at is function, occupational performance, and sexuality can be under self-care, leisure, not productivity. Well, it could, but no, that's a different story. All right, so what I'm trying to say is sexuality is something very private and personal, and don't feel like you have to be comfortable with it. It's okay to even tell your patient, I don't feel comfortable, but let's talk about it. Okay? So what I'm going to do today, in today's presentation, is I'm going to give you some definitions. I'm going to talk about, I don't have much time, so I'm not going to do a lot on anatomy and physiology. But I will talk about the response cycle because it's important to understand how things work and that. One thing, I will leave a copy of these presentations with your staff, and I'm happy to be emailed to you, right, or downloaded, or so if you want notes and things from both presentations, you can have them, okay? Then I'm going to talk about disability and how it's affected, or how sexuality is affected if you have a disability. And then I'm going to talk about factors influencing sexuality and intervention and some treatment ideas. And then we'll just open it up. We won't have time for case study because I'm looking at the time, but we'll have question and answer so we can, give examples, and I'll talk about some stories and things, okay? All right, let's start. So first off, I'm just gonna go over here into the Indonesian. Do you find having the slides with Indonesian and English, is that helpful? Is it accurate or is it just totally wrong? It's accurate, okay, that's good. All right, so what is sexuality? A lot of people, when they talk about sexuality, they only think about physical, intercourse, that kind of thing. That's wrong. Sexuality is everything about a person, okay? How you dress, how you interact. Me being a male, I'm a man. When I teach a class and when I talk about sexuality, would be quite different than if I was a woman. How we interact and talk to each other also is affected by whether you're male, female, etc. Okay? How you dress, like this morning, he said, oh, I'm going to this session at UI. I really like that boy, and I hope he notices me. So instead of wearing this, I'm going to wear this. I'm going to make sure I take a bath just in case he sits beside me, right? It's how you talk, how you interact. So when I look at this, we talk about body image, we talk about personality, we talk about gender, self-image, all of these things, your verbal, nonverbal communication. Think about how you interact with, if you're in a group of girls, compared to if you're in a group of girls and boys, or if you're the only girl in a group of boys. How do you talk and interact? Things change, right? Physical component of sexuality is only a small component, and yet people tend to focus on that. Can they have intercourse? Can they have an erection? Can they have whatever? That's not all of it. So when you're dealing with sexuality, many of you work in pediatrics. Did you know one of the biggest things that you need to work on in pediatrics is helping a child with a disability, help them develop their sexual identity. Now, what do I mean by that? You're helping them understand what is the appropriate behaviors for a boy, for a girl. How do you socialize? How do you talk? All of those things, if you do it properly, it's going to prevent some inappropriate behaviors, because when you have children, especially children with cognitive problems or autism and things like that, they may do things that are inappropriate. So if they see something they like, they might touch a woman when they're not supposed to, or touch a man or whatever, or touch themselves when it's not appropriate. It feels good for them, so they do it. But that's not right in public, right? So by developing their healthy sexual identity And again, it's not just about physical stuff. It's all about how they dress. Because even think about it, if you have a child with a disability, but you're helping them gain confidence about their personality and their self-image, how they dress, how they carry themselves will make such a difference in how they interact with everybody when they start going to school and stuff. That's all part of sexuality. Okay? So physical part of sex is a small part, and it's not the most important. As occupational therapists, we work with all the other stuff too. Okay? Sorry, picture, but okay. So in terms of male anatomy and female anatomy, you can look at textbooks, learn about it, but it's important to understand function so that if you're working with a patient who has some physical problems, then you can help explain that. So how is the stroke affecting their ability to have an erection or have sex or positions? Okay, so it's just important to know these things. But just one thing about the male penis and it is, as you can see, it's not just one part. It's not an organ that just fills with blood. There's many tubes inside to make it stronger and more rigid. Because remember, when we have sex, biologically, the body is always trying to have babies. Okay? Whether you want babies or not, that's not the thing. But as animals, when we have sex, our bodies are trying to procreate or have children. Okay? So that's why the function is always biologically driven. Okay? And I'll explain that. Now, you can talk about it, but just simply, in a male, sperm is produced in the testes. Then the sperm actually, as it matures, and it takes up to 70 days for sperm to mature, then it goes into the epididymis, then it moves up, and when a man ejaculates, the sperm goes up, and then there's a prostate gland and the seminal vesicle gland, which actually helps put all of the semen together. Now, sperm or semen, only 0.5% is sperm. The rest of it, prostate fluid and seminal vesicle fluid, is to help protect the sperm. Prostate fluid it's like a suit for the sperm. It protects it, gives it a nice environment. Seminal vesicle fluid is sugar, so it's energy for the sperm. So when the sperm goes into a woman, it has energy to get to the egg to fertilize. Okay? So that's basically it. And a man's penis is much bigger than what it looks like on the outside. The reason for that is, if you look at it, half of the penis is inside the body. Because what that does is when a man has an erection, it becomes much more firm, and because it's going deep in the body, it doesn't break off. Okay, so because again, it's for penetration, and by giving a woman pleasure, when a woman has pleasure during sex, her chances of having a baby goes up dramatically. So when you talk about pleasure, there's a function to pleasure. Otherwise, we wouldn't have pleasure. Because you have pleasure, you want to have sex. But when a woman is having sex with a man and she has an orgasm, automatically the chances of fertilization goes dramatically up. There's a physiological reason for that, but we don't need to get there. For a woman, basically, again, from an external perspective, the woman has, if you look at it from the outside, there's the clitoris, which is the only function for the clitoris is pleasure. Okay? But again, the reason for that is when a woman has pleasure, her body becomes more readily able. Also, a woman goes through a menstrual cycle, right? Now, if you know the menstrual cycle, it is all about procreation and having babies. Now, during ovulation, when a woman releases an egg, did you know that her hormones become more active during that time, And what that does is it increases her sex drive. So when she releases an egg, she wants to have sex more. She feels like she wants to have sex. Why? Because if she has sex during that time, she's more likely to have a baby. And if she feels like having sex and then she has sex and she has pleasure, guess what? Your chances of having a baby goes up. So a lot of women at different times of the month, they don't feel like having sex. And other times of the month, they feel like having sex. Again, what is a function? To have babies. But most people, when they have sex tonight in Jakarta, they're not trying to have a baby. They're having it for pleasure. Okay, and you have to acknowledge that. Pleasure is something that's important. So when you're working with your patients, you can't just think about babies and stuff. You got to think about they also want to have sex because it makes them feel like a woman or a man. It gives them pleasure. So there's all of these things that you as an occupational therapist need to work with them. Is that clear? All right. So when it comes to just female anatomy, I'm not going to spend much time, but you can see the vagina. Now the vagina is not something that's like a tube. It's actually just a flat, it sort of collapses on itself. But when a woman becomes aroused sexually, the vagina opens up to allow for penetration. So when a man ejaculates in a woman, basically what happens is the sperm goes into the uterus, and then it goes up into fallopian tubes. And usually if a woman ovulates, let's imagine she has sex tonight, okay? But she doesn't ovulate until tomorrow. The sperm, because it has sugar and also it has the prostate fluid, it is in a nice environment. So it's sitting in the fallopian tubes waiting. And sperm can live as long as 5 days. So you could have sex today, the sperm is sitting there, and you could ovulate, the woman could ovulate in 3 days, and as soon as the egg comes out, the sperm become active, because the sperm have a receptor, and it finds the egg to fertilize, to have a baby. Okay? So that's kind of the sexual anatomy, really quick. This is important. How many people know about the pubococcygeus muscle? How many people have a baby here? I know there was one mom. How many people have a baby? Any moms? Only one? Everybody else is embarrassed. So, do you know what the pubococcygeus muscle is? Anybody? Okay, everybody, you're going to do this here. Imagine that you're on the toilet. Okay, don't really do it, just imagine. Okay, so you're on the toilet, and whether you're a man or a woman, now imagine you're peeing, you're urinating. Now stop the urine from flowing. What muscles did you use to stop it? Okay, those are the muscles called pubococcygeus muscles. But those are only some of those muscles. I'll show you a picture. Imagine this is a person, you cut them, and you take everything out. So now if you look, you can see right at the front, you can see the part where you have in the back you have the tailbone, and you go up, and then you have the rectum. So that's where you poo from. And then you have the urethra, that little hole there, and so that's right in the front. The whole floor of the pelvic floor is basically your pubococcygeus muscles. Now, why is they important? So imagine there's a camera on the floor going up. So you can look at a man and a woman. Okay, when you have a baby, or as you get older, your muscles become weak. My wife, she had Cumber, twins. Twins do a lot of damage to a body. You can really loosen everything up. So then after, what happens is, as you get older or whatever, you have urinary or bowel incontinence. Do you know what I'm saying by that? Where you might have accidents. So sometimes a woman or a man, when they cough or they sneeze, a little bit of urine comes out. Okay? So as a patient gets older, they will find that these muscles get weak. Also, if you're sexually active, your muscles stay strong. But if you're not sexually active, those muscles start to get weak. Now, I'm not talking about sex here. I'm talking about bowel and bladder. Okay? So I had a patient. I remember she was about 60 years old, and she came in for a shoulder problem. So I was working on her, and then I did an intake interview. And I said, well, and then she told me she's wearing, what do you call diapers in Indonesian? Huh? Pampers. Okay, Pampers is okay. But she was wearing adult diapers. In Canada, many people wear that, older people. I don't know about here. Okay? I go, why are you wearing diapers? And she says, well, she had like 8 children. And the more children you have, the more difficulties you have too. And when she, if she's just anywhere and suddenly she has to go pee, if she doesn't get to the bathroom right away, she has accidents. And it's very embarrassing. So what she did was she started to wear these diapers, and she's been wearing them for a year. So I said, this is not good. So then I said, okay, let's see what we can do. So I put her on an exercise program. Okay? Now I'm going to teach you the exercise program. Imagine you are peeing. Well, no, a better way is imagine you're on the toilet, and I do this with my patients. I make them go on, especially old patients, you do it on the toilet, and you actually are there with them, and you teach them. The reason I say do it on the toilet, especially when you have elderly patients, is if something comes out, it goes right in, right? You're not going to have an accident. So you say, okay, now you're sitting on the toilet, and then imagine that you're going to the washroom. So you open everything up. So where you poop from as well as where you pee from. So you open all of that up, then you close it. Like a flower. Open, close, open, close, open, close. It's just like when you do any exercise, the same muscles. Okay, so basically what happens is you're teaching them to open it and close it, and you do it like open, close, open, close, open, close, open, close, not your hand down there, right? Okay, and you do it 10 times, rest, open, close, like 3 sets, and then you do like close, hold, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, relax. Close. Anyway, I put this woman on an exercise program. Then she came to see me about, I think it was 4 or 6 weeks later. And it was kind of funny. She used to wear only dresses. Why did she wear dresses? Because she wore diapers, if she wore pants, it looks not very good. So she used to wear dresses. But when she came in, she went, and she did this to me. And she was wearing pants, and I didn't understand. I go, and she goes, I'm wearing pants. And I go, I'm not having accidents anymore. Just by strengthening those muscles, it helped her with her incontinence. And as OTs, we deal with incontinence, right? We deal with bowel and bladder and all of those kinds of things. Even with children who have trouble with accidents, not young children, but older children, especially with their cognitive problems and stuff like that, if you teach them some of these exercises, it can help them control things a little bit better. Okay? Now, women who are pregnant. In Canada, I don't know how your obstetricians do it here, but in Canada, one of the things that all good obstetricians do with their patients who are pregnant is they teach them pubococcygeus muscle exercises. Because what happens is if you strengthen those muscles before you have the baby, those muscles, so when you have the baby, the delivery is a little easier. But also, after the delivery, there's less tearing. Sometimes if the baby's big, there's tearing. But also, the vagina and the area, the perineal area, returns back to previous health much better. And there's less chance of urinary incontinence and all those other problems. So it's really important to build those muscles up. So if you ever have a pregnant woman, you have to teach them these exercises. It's very simple. But a simple little thing is a huge solution. All right? All right. The breast. The breast is important. Now, as an occupational therapist, we do a lot of things with women for postpartum needs of women. Many of you work in pediatrics, but most of the kids that you work with are not infants, right? You don't work with babies, do you? Some of you might, right? I'm sorry? Lots of teenagers. But did you know we have babies who are born with developmental problems? And I remember one of my friends, they had a baby and newborn, and the baby was refusing to drink milk from the breast. And no matter what they did, the baby would have difficulty and would be crying, and they were using like special bottles and all this kind of stuff, but she wanted to breastfeed her baby. So what happened was I said, well, let me see. So I took the baby and I just started to check, and I was checking the reflexes for the baby. And you know how the baby has a sucking reflex? So if you ever have a new baby, you put your finger in their mouth and they automatically start sucking. That's a normal reflex. And then there's also, I'm sure you learn all your reflexes in your pediatrics course, but if you take a newborn and you stroke their cheek, right away the baby will turn to the cheek, right? And that's called a rooting reflex. The nipple plays an important role because when a mom wants to breastfeed a child, what happens is the breast, the nipple, strokes the baby's chin, and right away the baby will turn and start sucking. Now, this friends of my baby, like my friend's baby, I checked and it had a tongue thrust. So every time you put something in, the baby will go, like it was a abnormal reflex. Okay, instead of having a sucking reflex, it had a tongue thrust. But no one had checked for that, and I went, oh. So I said, well, let me see. And then I took my finger and I pressed down, and the baby started to suck on my thing. I said, okay. Then I told my friend, I'm sorry, this is embarrassing, but may I look at your breast? Right? And she went, what? I said, I'm a therapist. So then she showed me her breast, and I looked at her nipple. And like based on how the shape of her nipple, I suggested how to put the baby's mouth. And instead of just letting the baby, I said, you need to take your finger, stick it in the baby's mouth, press down. When it starts sucking, put your breast on it. And within 5 minutes, the baby was sucking naturally from the breast. And she's looking at me going, thank you. A simple thing that us as OTs can do to help with dealing a problem. Okay? So when you talk about sexuality, I'm not just talking about intercourse and all this. This is all part of sexuality. Does that make sense? And also, the men in the group, just because you're a man doesn't mean you don't deal with some of these issues for women. If your patient is a woman, you talk to them and whatever, but you have to be more sensitive. Like I would never, if I'm working in a clinic, have my patient show me her breast. This was my friend at my house, and my wife was there. Okay? But in the clinic, I would have my assistant there with me, so I make sure that I protect myself. Okay? And also make sure the patient's comfortable. So anyway, the size of the breast does not dictate how much milk a woman produces. I've lost my clicker. There it is. So the main thing is mammary glands, and we do play a role in breastfeeding and all of that. One more thing I want to talk about is menstruation. Okay? I actually wrote a book. If you want to Google it, it's called Menstruation and Me. You can buy it on Amazon. Don't buy it, but it's on Amazon. It became a bestseller. And they're actually looking at translating in Japanese. We should do it in Indonesian. But the reason, oh, did you bring the book? Oh, thank you. This is the book. What we did was we designed this book as an occupational therapist. So me and 4 other students, now they're therapists, we designed it so every chapter has an activity at the end. And it's designed for mom and daughter, or healthcare professional and daughter or kid, to teach them about menstrual care. But this is for population with special needs. I'll tell you why. I got called in, even though I'm a professor, but because my area is sexuality, they asked me for this because they had this patient, it was a young girl who had autism, okay, really severe. And she had a hypersensitivity to fluids and things like that. When she hit puberty, her menstruation started. And as soon as it started, she started to really panic. And she would like start screaming and things, and because there was blood coming out of her vagina. And she was just like, and mom and dad didn't know what to do. They had to, they tried to distract her and everything. But every time she felt some wetness, she would just scream and whatever. And during that time, those 4 or 5 days of the month, their whole house had to stop. They couldn't send her to school. They couldn't do anything because she was just really, 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 not able to manage. So they asked me, what should we do? So then what we did was we put them into a program talking about how do you get her to be more comfortable. So you know how we did it? We actually had, when mom had her menstruation, we actually had mom share with the daughter to show that, look, it's happening to me. And mom used to use tampons. I don't know if you use tampons in Indonesia, but do you do now? I know 20 years ago, tampons was not something, but pads, okay? So we got mom to switch to pads instead of tampons. And then what we did was mom would show how the blood comes out and how she wipes it and cleans and talk about it's a celebration. It's not a bad thing. And then slowly, she would help and kind of watch and things, and slowly we made her like desensitization. Then just about 3 or 4 months later, I had another call where this mom was really worried because her daughter was just getting to about 8, 9, 10 years old. She was starting to get little breasts, and you could tell that she was about to hit puberty. And they were really scared because she had a real phobia for blood, fluids, and same sort of thing. So what we did was, before she even had her period, we actually put her on a program. So when mom had her period, she would say, okay, it's that time of the month, special time. So then basically they shared the time. Slowly, so then the daughter was getting mad. You know why? She didn't have her period. Every month she was saying, when am I going to have my period? And when she had her period, it was like celebration, right? But again, this is where an occupational therapist can work with a patient. Now, how many people work with autism here? Some? Have you talked about menstruation with your moms and stuff like that, right? Because this could be a big issue, right? How are you going to deal with it? So anyway, these are some things you need to think about. Now let's talk about the sexual response cycle. So when you have the sexual response cycle, basically, this is what happens to your body when you are sexually active. Now, I don't know about all of you. Some of you are sexually active, some of you aren't. It doesn't matter. That's up to you. Whether you're alone, whether you're with somebody, the body goes through certain patterns. And men and women are very similar. And did you know biologically, the basic blueprint of our anatomy for men and women is female? Do you know that? But because of hormones, when you're 7 weeks in utero, 7 weeks of gestation, because of hormones and because you have XY chromosomes, certain hormones come into play, and then certain tubes become vas deferens, and then the penis grows and whatever, and certain tubes don't go away. And if you're a woman, those tubes become, the Mullerian ducts become the fallopian tubes, etc. The testes, in men, the gonads become testes. In women, it becomes ovaries. So same things, but they look differently in men and women. But basically, men and women are very similar. Okay, but how does a sexual response cycle happen? So what happens is you have desire, so you feel like wanting to have sex. Then what happens is your heart rate goes up, you feel excited. For women, they have lubrication. For men, they have erections. And then at plateau, it just gets at a higher state, and then orgasm we'll talk about, and then resolution, things return to a non-excited state. So what happens in each stage? There's a few differences between men and women. Women have the ability to have multiple orgasms. Okay? Men do not. Men have what's called a refractory period. Why do you think that happens? Any ideas? Why do you think women are able to have multiple orgasms and men can't? Is it God's punishment for men? Production of sperm. Kind of, sort of, yeah. It's not so much sperm, it's semen. Because we have lots of sperm. For the men in the group here, in the audience, they're young, not old guys like me, but young people. Every time I snap my fingers, they've produced at least 4,000 sperm. 4,000, 8,000, 12,000. Every time. So that's why all the men get really, no, but okay, but producing sperm all the time. But the sperm you produce today, you won't use until 70 days from now. However, remember, why do we have sex? Biologically, to have babies. Now, a woman, I said, when she has sex and she has orgasm, the uterus actually comes down, helps suck semen up, and actually everything becomes much easier for sperm and better environment. So for fertilization to happen, a woman having an orgasm is a good thing. Okay? So the more orgasm she has, the better chance of fertilization. And that's why when women like the men they're with and they want to have a baby, they're more likely to have an orgasm. But if they're having sex with somebody they don't like or don't want to have a baby with, they're less likely to have an orgasm. Does that make sense? But men, when we have sex, biologically, we want to make sure that when we have sex, it's the best opportunity for fertilization. So when a man has sex, remember I said how the prostate fluid shoots fluid and the seminal vesicle fluid shoots fluid. But then after that fluid is gone, guess what? He needs time to regenerate. Because if he has sex again, there's not enough prostate fluid and seminal vesicle fluid, so the sperm don't have energy and they don't have protection. So if the sperm goes out there, it's going to die. So why waste it? So basically what happens is, if a man has an ejaculation, if he's a young guy, it might take 15, 20 minutes. If he's an old guy, it might take 24 hours to even 48 hours. So sometimes your patients will say, when I have sex, it doesn't work anymore. I can't even the next day. Well, because he's getting older. So you have to explain that the refractory period becomes longer and longer and longer as you get older. But how do you make it stay short? If a man is sexually active all his life, when he's older, his refractory period won't be as long. But if he's sexually inactive all his life, then when he gets older, it might be as long as 48 hours. Okay? Because if your system is working well, you can reload, and the prostate fluid and the seminal vesicle fluid can reload faster. But even then, as you get older, it gets slower. Okay? So that's the big difference between men and women. Now, this is a picture of a woman, unstimulated on the left. As she gets excited, notice how the uterus pulls back. And then plateau, the uterus pulls back even further. And then when she has an orgasm, the uterus actually goes down. Now, notice I have that little pool of seminal fluid, right? So if a man has sex and the sperm is in there, then what happens is the uterus actually goes in and pulls semen into the vagina, like into the uterus, so it can go up the fallopian tube, so it betters the chances. But notice after a woman has had an orgasm and all that, and they've stopped having sex, notice where the opening of the uterus is. It's right in the pool of semen. So guess what? Chances of fertilization is higher. The body is always putting itself in a position to have babies. So if you're sexually active and you don't want to have babies, you better use some protection and do it carefully, okay? Because the body is always going to try. All right, for male, I've already talked about this, so I don't think we need to talk, but I've mentioned all of this, so we'll just move on. Now let's talk about impact of disability on sexual functioning. All right. The first thing is, in general, what you'll find is if a person has a disability, now I'm being really general because there's so many disabilities, so many impairments. So you could have someone with a spinal cord injury, you could have somebody with trauma, you could have somebody with whatever, schizophrenia. There's so many different things. So each one will affect sexuality differently. So I'm just going to talk about it from a general perspective. Then what you need to do is if you have a patient who's had a stroke, then you might say, okay, I'm going to go into the internet and I'm going to find out. Or you might even ask ChatGPT and saying, please tell me the impact of stroke on sexuality. And then it'll give you some information so that you can use that information with your patient. Okay? So generally what you'll find is a person's ability or their drive to have sex may go down. It may affect their ability, their behaviors around sexuality. So they might not be able to get into certain positions and stuff. And then they might also just overall satisfaction, their inability to have satisfaction. You don't have multiple sclerosis here very often, right? It's very rare in Indonesia. In Canada, in the area that I live, because it's in northern Alberta, we have so many multiple sclerosis, so many people with multiple sclerosis. It's a neurological condition. And one of the things that is affected greatly is sexual functioning, both men and women. Men have erectile problems, women have orgasmic problems. But remember that pubococcygeus muscle I talked about incontinence? It can also play a role in pleasure. So if a woman has trouble having an orgasm, if you strengthen those muscles, her orgasms become more intense. Also, this is kind of whatever, when a woman is having sex with a man, for those of you who are in relationships, might want to try this, if you strengthen those muscles while you're having intercourse, you can press down on those muscles and it can be very pleasurable for yourself as well as for your partner. So to increase the pleasure in your sex, you can do that. But also, if a man has trouble controlling his ejaculation, he comes too quickly, that's not a good thing. So it's called premature ejaculation. If a man strengthens those muscles, he can learn to control his ejaculations. Okay, so guys, if you're having trouble, you might want to strengthen those muscles, okay? So let's talk about stability, attitudes. Generally, what you'll find in society is if a person has a disability, automatically they're seen as asexual. They're not seen as sexual and all that. I use this cartoon, and it says, nice to see her go out with a guy I don't have to worry about. After all, he is in a wheelchair. What meaning do you get from this? Anybody? What meaning do you get from this cartoon? So there you have mom and dad watching their daughter going out on a date with a man. And they said, oh, we don't have to worry about him because he's in a wheelchair. He's not going to take advantage of their daughter. Okay? But you look at his face, he wants to have sex. Okay? But there's an attitude that if you have a disability, oh, you're not sexual. That's not true. I remember one of my friends, he's still a friend of mine, when he was 16, he jumped off like a pier. He was swimming, and he jumped into the lake, and he hit his head on a rock, and he suffered a spinal cord injury. So he became a quadriplegic when he was 16 years old. So there, he was in the hospital for months. This is, so he's in the hospital and like going through rehab and therapies, getting OT, PT, all that kind of stuff. And then he was getting to the point where he could go home, but he was from a small town in where I live, around there. So he couldn't go home on the weekends, but his girlfriend lived in Edmonton. So what happened was his girlfriend and his girlfriend's parents would come, pick him up, take him to their house for the weekend, and he would spend the weekend at their house. Now, he was only 16 and his girlfriend was 16 years old. But you know what they did? The girlfriend's room was in the basement. We have basements in Canada. Okay, so that's bottom floor. They actually set up a bed for him in their daughter's room. Now, how many parents would allow their daughter to have their boyfriend in the same room overnight? Not here or not in Canada even. This was 30 years ago. Now maybe, I don't know. But not many. But they felt, oh, he's safe. He's got a spinal cord injury. He's a quadriplegic. Poor guy. He's not going to do anything with her. During that time, before the accident, they had never had sex. In Canada, people have premarital sex is very common. In fact, most people have premarital sex. But these two had never had sex. They'd kissed and hold hands and that kind of stuff and whatever. But during this time, on the weekends, he would never sleep in that bed. He was always in the girlfriend's bed. They would mess it up in the morning to make it look like he slept there. And during that time, him and his girlfriend did a lot of exploration. Like they explored, and they did have sex. But what I'm saying is the attitude was the parents said, oh, he's never going to have sex because he's got a... So what I'm trying to say is just because you have a disability doesn't change your feelings, thoughts, emotions. What it changes is your ability to do certain things. So you're not able to maybe do certain things, but you can change that. And that, as OTs, we can help them. Oh, I'm looking at the time. Okay, so generally, what's affected? So you have body image, self-esteem, public attitudes, past and current relationships. What you'll find is if your patient is in past relationship or has a relationship, they're more likely to resume sexual activity. If they're not, they usually avoid it. So you can be there to help them understand. And a lot of things around sexuality isn't about penis, vagina, intercourse. It's none of that. It's more around acceptance, like counseling, helping them understand and come to terms with how their body has changed. Also helping them reestablish their sexual identity, who they are as a person. Also, a lot of times with men, when they're not able to have sex and things aren't working, they feel less of a man. So their whole manhood. And women also feel like they're not a woman and they're like a second-class woman. So they, again, devalue themselves. So as OTs, you need to work with them to help them reestablish who they are in their own sense of body image, self-esteem, and all of that. So a lot of sexuality is around psychosocial, and really you don't have to deal with penis, vagina, and all that kind of stuff. In terms of response and fertility, depends on the disability. They could have full function or can be affected significantly. There might be increased arousal, decreased arousal. So all of these things, birth control is still an issue. Okay? I'll give you an example. Did you know when a woman has trauma, like let's imagine you have a woman who is driving home tonight and she is in a car accident or in a motorbike accident. She suffered a spinal cord injury. Automatically, your body goes into self-preservation mode. So a lot of times women will lose their periods during that trauma. So a lot of times women will say, well, I don't have my period anymore, so I'm not going to get pregnant. But that's not true, because the body might start again at any point. So you still have to think about birth control if they don't want to have a baby, right? So explaining and teaching a lot of these things. Now, behaviors. Again, depending on the disability, it's going to affect how they do things, what they do. So you might be the one, if they're having trouble with certain activities, how can you help them? How can you use assistive devices to help them increase function? Now, you know how you can get toys, vibration and all of that? When you have a disability, sometimes because your partner or yourself don't have the mobility, strength, it might be weakness, you can't have the same level of stimulation. So by using assistive technology or assistive devices like a vibration or whatever, it can help with pleasure. So you can use these things, or you can use different things to help position for sex and all of that. Okay? And yes, in Canada, all my students learn about this, and they actually work with patients to talk about what positions would be best for pleasure, but also for function and all of that kind of stuff. What positions and all that. Okay? Choice of activities. So maybe they can't have intercourse anymore. Maybe they're looking at other pleasure activities. Did you know, whether it's Indonesia or whether it's Canada or around the world, as people get older, in fact, they did a world survey of older adults, and what you'll find is, even in Indonesia, older people are having more sex in China, Japan, Indonesia, all the Asian countries. People are having more sex when they're older than they are in North America. Okay? However, the North Americans are having more pleasurable sex, while Asians are having more frequent sex. Okay? So your parents and your grandparents are still having sex. Whether you like to believe it or not, they are. But also what you find is, as people get older, they're having less penetrative sex. So they don't have intercourse as often. But they do other things like physical, manual activities. Okay? Whether you like to think about it or not, they do have manual activities. So this is something that if you understand, you can say, well, if you can't have penetration, maybe you can try using your hands or whatever else. Positions for intercourse. It's just like activity analysis, except maybe we look at occupational analysis, so it's meaningful and engaged activity. But you're talking about, well, what position? If you have this problem, this mobility, this spasm, what positions would work? How would this work? So it's just doing an activity analysis and putting yourself in that position. It's okay, would that work for this patient? Anything like that. Sexual expression, just allowing for expression. And when I say sexual expression, what if your patient wants to wear certain types of clothes to help express themselves sexually, which is fine. Or they want to do their hair, their body image and all that. So it's not just about physical expression, it's also about, showing that you're a woman or a man or whatever. So those are the types of things we might help with. Now, what are some big concerns? One of the big things that people with disabilities talk about is just not feeling like a man or a woman, feeling like their body parts aren't working, and that would affect how they do things. Feeling unattractive. Because I have a disability, I'm not attractive anymore. They feel that a threat to their capacity to be loved. So they feel that because they have a disability, they're never going to be loved again. Okay? Threat to their identity. Notice all of these things are more psychosocial. So you as a therapist, all you need to do is you don't have to have the answers. You just listen, talk to them, and what you'll find is just by bringing up the conversation, it really helps. They feel untouchable, feel inadequacy, do that. Now, what are some other things that may affect because of the disability? So there's other conditions. Did you know, how many people know somebody who has diabetes? You don't know anybody with diabetes is such a big common problem in Indonesia, right? Did you know if you're a man, if you have diabetes, 90%, 90% of men, so almost all men with diabetes will at some point in their life develop erectile problems. 60 to 70% of women with diabetes will have arousal problems because sensation and nerves and stuff in the genitals get affected. So a woman will not feel pleasure. She'll be having numbness and tingling in the genital areas. So diabetes can be a huge issue. Then you have things like cardiovascular disease. In Canada, I don't know if it's like that in Indonesia, but they've brought in new guidelines. Doctors, when a man turns 40, one of the questions they are taught to ask, this is part of their assessment, is to ask a man about their erectile function. Because what they've found is if a man has erectile function problems when he's 40, like he's having trouble getting an erection or he's starting to get not as good, that is a guaranteed that he'll develop cardiovascular disease in the next 8 to 10 years. So what they're using it as a screening. So if a man has erectile problems at 40, right away the doctor says, okay, you need to get tested to see if you have cardiovascular disease, get put on like blood pressure medications or statins, to deal with cholesterol and stuff like that, because that they found is a better predictor of heart disease than anything else. But what I'm saying is all of these things can have an effect on sexuality. Then you have sensory stuff like spasms, spasticity, all of those may affect sexuality, and then also hypertension and stuff. Psychologically, we've already talked about all of these, so I don't have to mention that. Now, in terms of men, when it comes to sexual functioning, you have erection problems, all that. Did you know psychiatric medications are really cause a lot of problems with sexual functioning, both for men and women. For women, it can cause dryness. For men, it can cause erectile problems or ejaculatory problems and stuff like that. And sexual side effects is one of the big reasons why people with psychiatric conditions stop taking their medications. So this is something you need to talk to the patient about, saying, well, why aren't you taking your medications? And they might be embarrassed to say, well, it's because I'm having problems with my sex. So then you talk to them, and you might talk to the pharmacist or the doctor and saying, well, can we change the medication? Because there's some medications that have more effects and some less. Some of the newer medications are way cleaner and have less sexual, like the old, like Paxil and all of those kinds of things had huge like antidepressants and stuff, but the newer ones actually are quite good. For women, basically fertility in most cases with disability doesn't get affected, but may be affected. But generally there's pain. Pain is a #1 problem for a lot of women, and how do you change it? Now, one of the things that I always say as an occupational therapist is if a woman is having any sort of pain during sexual activity, but you should say stop. Don't do it until you deal with the problem. But if she insists on saying, no, I have to have sex because it's my husband, blah, 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 etc., the first thing I would say is suggest an artificial lubricant. KY jelly or anything like that. There's lots of artificial lubricants, because if she has any numbness, or maybe if it's spinal cord injury or whatever, because she can't have sensation or she's having pain, the lubricant will protect the genitals And if she's having pain, it'll make things a little smoother, a little more comfortable. The other thing is you change positions. So you ask, what position do you have sex with your partner? And I always say, if a woman's having discomfort, you always say she should take the top position. By taking the top position, what happens is she can control how deep the penetration is and all that kind of stuff. So it becomes a little more comfortable and she can protect herself. So just little things like that is what you talk about. And I mean, it's unfortunate we have so little time because generally, now this isn't working. Generally what I spend, like with my students, we do 20 hours of sexuality. It's not working. Can someone, I know time's up, but I can't flip. Oh, that's how it works. As soon as time's up, they stop PowerPoint, right? Well, it's just a binary summary slide. Oh, there we go. So generally what you want to do is help the patients resume activities. There's different activities like body mapping. This, I'm going to take 2 minutes, I don't care. Okay, but body mapping is a little activity that you do. For example, if you have a disability, it's where the person with the disability just lays down and their partner explores their body. So you're looking at what parts of the body feel good, what parts are doing. So just because you have no sensation in certain areas, there's other areas that might become more sensitive. So what you're doing is mapping the body to see where pleasure areas are. It doesn't have to be traditional. You talk about positioning, increased amount of foreplay and all those kinds of things. And then for erection, I've got some things. But like I said, we'll share this and there's information. There's different things. Viagra, all the different things for erection, lots of stuff for men. And then for women, there's lubrications and all that kind of stuff. And then who does it? And then just in terms of interviews and stuff like that, you just want to talk about asking questions about desire, excitement, orgasm, and resolution. I think. And yeah, we'll share this with you. So lots of psychosocial, which I've already talked about. And so just make sure when you are looking at sexuality, you want to make sure that you understand it's important and you don't have to have the answers. All you have to be there is you as an occupational therapist can spend time with your patient to talk and really listen to their concerns. And then together, participate together, participation, occupational participation, together you come up with solutions. All they need is permission. All they need is someone to tell them, hey, it's okay. Just because you have a disability, you can still be sexual. And no, and we will spend half an hour answering questions, not only about sexuality, but also current trends in occupational therapy and that. So I'm sorry we didn't have much time, but I hope this gives you sort of an overview of the importance of sexuality and how, as an OT, just these little things that can play a role in, whether it's around menstruation, whether it's around, even something in developmental things for children, or, helping them with their own body identity, self-perception. All of these things are important. It's not just about penis in vagina. That's not just sex. Sex is who you are as a person too. Okay? All right. Tofik, yes.
Thank you for a wonderful speech, Professor. My question is about OT's positioning in the culture, and then we call it main or issues that concerning about sexuality now. I mean, like this, is it in viral about one of the communities that has mostly Muslims? And then there's some event that happened. What's OT's position in that situations actually?
Okay. I think whether it's Muslim, Christian, doesn't matter. Okay. But our role is to be culturally sensitive. So if you know that a certain religion or whatever, because of, now, I've worked with lots of Christian patients, and some of them are very conservative, And some of them are very whatever. In the same way, I know a lot of Muslim, same thing. So you have to be understanding of the culture and also their belief systems, because if you look at my first slide, way up at the beginning, if I went way back, I forgot to mention this, but this is the most important thing when it comes to sexuality. Whoa, there's a lot of slides. But let's back up. In my definition, look at this. Right at the top, when it comes to sexuality, the most important thing, notice I've got beliefs and values. That is part of someone's religion and their value systems and all that. So when you're looking at sexuality, all that other stuff is important, but at the end of the day, you have to respect the person's values and belief systems. Okay? So if a patient is not able to have intercourse, and you might say, well, you might try manual or whatever, but that is something they just don't accept, then you have to accept that, and you can't force them to do something they're not comfortable with. Oh, the other thing when it comes to sexuality, you can't force a patient to talk about it. So just because you know a patient has trouble, if you went to them and say, oh, sexuality might be affected because of your stroke, and they said, I want to talk about it, you need to back off. You can't force a patient to talk about it. A lot of times their husband or wife will come and talk to you to bring it up, then you talk to them together. So that might be something you do as a couple. Sarah, sorry. Is that yours working? Okay, go ahead. Do I come up here? I'm going to go around. My knees aren't. What do we do? Okay.
So, thank you very much, Professor Shanif. That was a very comprehensive presentation. So, ladies and gentlemen, after we know about the occupational therapy practice in Indonesia, now it's time to have a discussions with our speakers. Ladies and gentlemen, now come to the questions and answer sessions. I would like to have 3 questions from the participants. Please introduce yourself by telling us your name. Thank you.
Thank you. Hello, Shanif. My name is Ian. I work with children in teenager, special need children in their teenager phase. A couple years ago, I worked with children, small children, and now I work with teenager. And special needs, they have a lot of sensory issue back then. And then when puberty hits, the sensory issue become more very, very difficult for me. And
so I'm going to say it for you because you're not saying it. They're touching their penis. They're touching, like they're self-stimulating. Is that what you're talking about?
Not only like that. Maybe like their self-steaming coming up again, and then sometimes parents become more like, there's such thing that already gone. Why there's come back again? And sometimes we have as an OT, we know that we have a lot of methods that we use for treatment, and then for teenager, I still figure out what method that I have to use for them. Sometimes I work with psychologists because I think for me, because I don't work with a lot of teenagers before, so I still learning about it. So for me, sometimes I need a psychologist. Sometimes I recommend to psychiatrists to get them medication. And for OT, what can we help for them?
Okay, so first off, a lot of times people, OTs discount our skills. We have the skills because we do a lot of behavior management. And the psychologists will do the same thing, behavior management, but we do it better because we look at it from a functional perspective. So now medications, there's ethical issues around that, because should you be giving a child medications to control their behavior? So ideally, we should be teaching them skills to be able to control their behavior without using medications, because a lot of times what happens is they use like the same medications they use for compulsive disorders, they use it to control behaviors, especially when you have children who have autism or, like cognitive issues and things like that. But what I find is when you have a child, for example, who is doing some self-stimulating behavior, I'll give you an example. In an Edmonton school, there was, like where I'm from, there was a young boy, very nice boy. He had developmental disability, plus he had autism, and I can't remember what else. Like, it was a complex, but he was really a fun child, and everybody liked him, and he whatever. But when he hit puberty, he started to touch himself because it felt good. He started to do masturbation, okay? But he was doing it at school. And his mother was a very conservative Christian woman, and she was just going, this is bad and sinful and all that. So what they did, he had problems with incontinence too. So he used to wear a diaper, as you know. So what they did was she put a belt on top of the diaper, so it prevents him from putting his hands in his pants. Okay, and also what they did was at school, they got all the teachers to watch him. Every time he tried to do any self-stimulating behavior, automatically they'd get mad at him, they'd punish him, he'd lose privileges and all that. And then at home, they had one of those TV monitors in his bedroom. So even at night, if he tries to touch himself, she'd run in and yell at him. Okay? Now what happened was this really nice, friendly child became very quiet, very withdrawn, very angry. And what happened was at school, he was always just the nicest child. Everybody liked him. He punched another child. And at this time, one of the teachers or someone, there was an OT that called me and said, we have a problem here. Because she was trying to explain that, we need to do something, but they wouldn't listen to them. They called the expert, me. So I came in there and I'm talking to vice principal. And the vice principal goes, he was all happy. We stopped him from masturbating in class and we stopped the behavior. I said, So what you're telling me is you stopped the behavior, but this child who was interacting, learning, participating in class now doesn't do that. And now he's hit another child. So tell me what's better. Then I had to sit down with the mother and I said, I understand your belief system. You think masturbation is sinful, but he doesn't understand. He doesn't know that it's right or wrong, whether it's a sin or not a sin. He doesn't have the cognitive ability. So I said, he's going to do it because it feels good, but now you stop the behavior, but that energy needs to go somewhere. So what I said is, isn't it better that he does it at home so that at school he stops the behavior? Also, so we had to change this. And then at school, what they did was when they noticed he was trying to do that behavior, because they took the belt away and stuff, as soon as that happened, their teacher assistant would take the child and take him to a private room. And many schools that have kids with disabilities, because in Alberta, in Canada, we use integrated programs. So our children with disabilities are integrated into the classrooms, but we put services in to support the teacher. So now many schools have what's called private or quiet rooms, where the child is taken and actually allowed to do self-stimulating behavior, so that they know that it's okay in that safe environment to do it, and then it stops in the classroom and all that. So this was a way of controlling the behavior in a safe way, but allowing for the child to actually express themselves. So it's sometimes we try to stop a behavior, and in reality, it's hard to stop something. It's better to redirect it. And I always say, if they're not allowed to eat ice cream, can they eat cake? Because what you're trying to do is replace one behavior with another. If you try to stop a behavior without replacing it with something that's just as positive, you're not going to be successful, right?
So when we work with teenager
Mhm.
with that behavior, where is OT position and where is a psychologist position? Because
I think in that case, especially if it's a child with cognitive issues, I really don't see a big position for psychologists. They're not as relevant. We are the more important people because we have the skills. We look at function, we look at behaviors, we look at, general environment. Honestly, I think a psychologist is trying to do something they're not trained to do in that case. We are better positioned to do that.
but in Indonesia,
Yeah.
that's psychologist position.
Well, even in Edmonton or even in Canada, same thing, and there's a fight. Psychologists are trying to, because they're afraid, because they're realizing that OTs are starting to do their job. And this is what like I said, remember in one of my slides and earlier, I said more prominence of mental health, because what they're starting to realize, the way OTs do mental health is actually much more powerful and much more effective than what psychologists do. And they're scared because we're entering their territory and they don't want that to happen. So they're being very protectionistic. So it's just working with them, being nice, but at the same time saying, well, why don't you try this? Because we approach things from a different perspective, right?
Thank you.
Thank you so much, Professor Shani, for the answer. I'm going to open for the second questions.
Okay, let me introduce myself first. My name is Pradit. Professor Sanif, I would like to ask you two questions, if you mind. For the first question, we know that the possibility OT can expand in Canada is so much wider than Indonesia, but in our maritime country, I think it's a lot of work to do. Can you give me some example that OT's area that already been expand, like you were mentioned about industrial, and can you explain that? And is it possible that it can be apply also in Indonesia?
Okay, that's one area when I was looking at practice in Indonesia that is the most difficult is industry. And I'll tell you why. In Canada, if I'm working in a factory and I get injured, we have workers' compensation. So automatically, the industry or the place that I'm working, they have to have insurance. So automatically, if I get injured on that site, they have to pay for all my medical, all my rehab, and they have to ensure that after my injury, I can return to some work. And if I can't work in the job that I used to do, they have to create a new job that I can function at, because it's their responsibility because my injury happened at their work. Okay, so that's why they like occupational therapists, because what we do is we go in and we talk about quality of life, environment, and all that. So we actually do proactively try to injury prevention, safety, using ergonomics and all of that to make sure that everything's good. So there's less chance of injury. However, if there's an injury, then we work with the patient to allow them to go back to work. And we adapt and change and write all of that kind of stuff. But in Indonesia, you have a problem. Because if I'm working in a place and I get injured, from what I understand, in most cases, I'd get let go, and there's 100 people to take my job, right? Because there's so many, like you have people in Indonesia, we don't have people in Canada. We have a shortage. Did you know that when I go to a restaurant, when I go to a store like Matahari or whatever, here you have so many people helping you. In Canada, you're looking and you go, is there anybody working here? There's nobody there because there's not enough people to do the jobs. And that's why we actually like immigration, because we're trying to bring in more people because there's not enough people to do the jobs. There's all these shortages because we don't have enough people. That's why, we can play a role, but in Indonesia, unless there's specific things within the work, if there's no insurance and nothing, and there's no responsibility from the employer, they just get another person, and this poor person is gone home, and they're going to be disabled, and they're going to live in poverty probably. So right now, the way Indonesia is set up, the role of occupational therapy, they can be there for injury prevention, but post-injury, I don't know what kind of role there is because of the way the system is and the fact that you have such a huge population that human resources is disposable here, unfortunately. I don't mean to, but that is a reality, right? So that's one area that probably that OT, I don't see it growing right now, but if they bring in laws and stuff to protect the worker, as soon as that happens, and if there's unions and stuff, then you can see OTs coming in. Because we have unions, and unions insist that there has to be safety and OTs and blah, blah, blah. Good question.
Thank you for your answer. Okay, so population does really affect some.
It does.
Okay.
Most definitely.
Okay, and I have another question. This is one of my case. This is a 7-year-old girl. She recently display some like pressing her kind of lower abdomen area when she's frustrated, and sometimes I also worried that it might cause harm in her vagina.
Yep.
So I was wondering if we cannot ask her to stop that behavior, of course, but I was kind of confused to tell the parents that like the same like your cases, like the mother is very conservative Catholic.
Yep.
So it was hard for me to explain it. Can you have some?
Again, the mom's going to notice too. She's not blind, she'll see this. And what you want to do is kind of, remember when I said, where I said cake or ice cream? So right now she's trying to self-stimulate by rubbing and all that, and you're afraid she's going to hurt herself. I remember we had one patient where she was using a hairbrush to do that, and she was damaging her, like she was tearing the skin. So what we did was we changed the hairbrush to something softer and we put a lubricant on it, so some lotion. And when she did it with the lotion, she really liked it. Yeah, so she was doing it before with a brush. Now she has a lotion and a thing, and by giving it to her, she knew that that was the time to do it, and it became much more comfortable, and she wasn't hurting herself. In the same way, what we've done with children, when they are doing some of those things, is buying them a toy that's just a plush, like a soft toy or something like that, and then allowing them to kind of show them that, oh, when you're rubbing, put this toy there. And they will learn that that feels better, they're not hurting themselves. And also because the toy is something that you see children with all the time, it's not as embarrassing, you know what I mean? So you can do something like that.
Okay, thank you for your answer, Mr. Sanif.
Thank you, Professor Shani, for the answer. I'm going to open for the last questions.
Hello, my name is Azza Khairunisa. I am an OT student here. And my question is about the research about sexuality and occupational therapy in Canada, and how you and University of Alberta conduct the research, and how do we can apply that research in Indonesia, especially because sexuality is kind of taboo in our culture to talk and to really said that out loud. So maybe we can share a little advice or research thing about that.
Okay, so unfortunately, when it comes to disability and sexuality, there's very little research. Okay, myself, for my PhD, so S3, my area was impact of disability on couples' sexual relations. Okay, so that's where I started my research, and I did a big study looking at, impact and kind of looking at male and female differences and how whatever. But unfortunately, I'm one person, and there's not a lot of people doing research. So you can find, if you look at a disability, if you look at spinal cord injury, then it'll give you the pathophysiology of spinal cord injury and its effects on sexuality and blah, blah. But there's not a lot of research from a psychosocial perspective or a qualitative research perspective in terms of understanding attitudes and perceptions and stuff. But for myself, as an OT, what happened was, even though my initial part was on sexuality and disability for adults, I started to get a lot of questions around children around sexuality. So then my research all switched to looking at sex education for children with disabilities. So my research, a lot of it is in the area of sexuality and disability, but more around sex education. Then in the more recent years, I haven't had time because I've taken more administration, I've become, director, all that. So I haven't had time. But more recently, where all my work is coming in, is I'm getting a lot of people calling me about intellectual disability and sexuality. Because what's happening is, because of a lot of our students are now in the classrooms and stuff, you're getting behaviors that are happening, right? So I'm hoping that next year I'll have a sabbatical. So what I'm trying to do is publish some work. I just published a paper looking at consent. Because to be able to have sex, you need to consent. But if you don't have an intellectual capacity, if you don't have the capacity to consent, how can you have sex? So I wrote a systematic review. It's the most comprehensive review in the world, actually. But so we just published that. But unfortunately, finding research is limited. But you need to look at disability specific and then do a search on that. For the U of A, where we are, again, I'm the only person, and I haven't done a lot of research in the last while. But I am doing a lot of work in terms of publishing, or doing educate the educator. So I'm doing a lot of workshops and stuff to teach people on how to deal with sexuality. But unfortunately, that's a reality.
Okay, so there's still a limited research about, and also a limited resource about sexuality and disability.
Yes.
For occupational therapy.
Again, when you say occupational therapy, you can take occupational therapy out and just look at research around sexuality and disability. And then as an OT, you apply what we do using that research, right? Because in terms of OTs around the world, there's maybe a handful of OTs that actually do research in the area. There's lots of OTs that do sexuality, treatment. But when it comes to research, there's maybe 3 or 4 or 5 of us in the whole world. So not very many.
Okay. Thank you very much.
Okay.
Thank you, Professor Shani, for the answer. Ladies and gentlemen, before we come to the end of the workshop, please allow me to also take some highlight points from this today's sessions. So for the occupational therapy practice in Indonesia, trends and challenge in occupational therapy educations and clinical practice. For the occupations is our core domain of concerns that defines our professional identity, differentiating us from other health professionals. Occupations give a sense of identity and contribute to overall well-being and quality of life. The value of human touch, empathy, and personalized case in occupational therapy is important. And for the highlights of sexuality and disability and occupational therapy, first, sexuality is mostly a learned phenomena and has physical, emotional, and spiritual aspects. There are many possible factors influencing sexuality in patients with disabilities, such as medical factors and psychological factors. Second, as an occupational therapist, we could incorporate sexuality into everyday life practice for our patients by provide general counseling, remove communications barriers, suggest alternative positions, etc. Thank you. And finally, ladies and gentlemen, I would like to thank the speaker, Professor Sanif, to your informative and interesting sessions, and also to all the participants for your participations. Please give applause for the speakers and for the participants.
And I want to thank you all, because I know most of you are on holidays. It's summer holidays, so the fact you're coming here for that really shows that you're engaged and being participation in your profession. So that's good. There's a few of these neck things if you want them. I'll just leave them up on the stage. You can come and take, okay?
Thank you, Ms. Sarah Wulan as moderator for guiding the material session in today's public lecture, as well as Mr. Shanif Ismail for giving us an insightful presentation that will surely serve a purpose in the future. All right, ladies and gentlemen, we have listened to the presentation material on current trends and challenges in occupational therapy education and clinical practice by all our amazing speakers, and the material is amazing and certainly provides new insights for all of us. Before we end the event, there will be a submission of certificate to Ms. Sarah Wulan and Mr. Sanif Ismail by Mr. Hermito Gideon.
Mr. Shanif Ismail and Ms. Sarah Wulan, also Mr. Hermito Gideon, please come up to the stage.
Oh, siap.
Thank you, Mr. Sharif and Mr. Hermito Gideon. And also we want to please welcome Miss Iin Mutmainah from Iluni. Miss Iin will giving the certificate to Miss Sarah Wulan.
Ini kan dokumentasi udah. Jadi langsung.
Thank you, Miss Iin and Miss Sarah. All right.
Now that the certificate submission is done, the public lecture is officially over for today. Once again, I would like to thank all participants who have attended the public lecture from beginning until the end. Hopefully, the lessons given today can be useful for all of us.
We apologize if there are any mistakes or shortcomings. Bianca Azara and I, Yosepin Talita, had to say goodbye. We hope that we can meet again in another occasion. See you soon and Shalom, Om Santi 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 Om, Namo Buddhaya, greetings of virtue. Thank you so much everyone for attending today's event.
Ngawi. Daerahnya panas. Iya panas Pak. Super cold, makanya gue nggak mau kan. Super cold, bener. Ini minuman lu bang, iya. Tadi. Iya foto sama. Kamu udah lulus. Ayo, Pik. Dulu nih. Ayo, lu. Ayo, salah. Ayo Iluni, Iluni. Berdiri, adik berdiri. Dokter sini, dokter Iluni kan? Kemana? Yang udah lulus. Ayo Iluni. Iya aja bukan. Ayo Mas. Iya beneran. Lena. Miring.
We need to get closer. Okay. Squeeze.
Ya, dua balik.
Okay. Hold the breath. Yeah, that's good. Okay, everybody stomach in. All the men.
Anak Sameo, Sarangeo. Tunjuk Sanif. Oke. Handphone nggak ada? Handphone nggak ada. Handphone, Pak Eja.
One more, ya.
Bumerang.
Nah, satu yang landscape potret buat story IG.
Iya. Oke. Ya, di blow up. Ya.
Story ya, Instagram.
Tunjuk Sanif. Nah. Landscape. Ya udah cukup lah. Udahlah. Cukup banyak.
Welcome. Thank you.
Udah lama gak ketemu ya? Iya.
Iya kak, mau foto bareng nggak kak? Tapi berempat sama Mas. Sama